Hello everyone, this is Dr. Pruitt. Welcome to this week's EKG. We're going to start with a 61-year-old male who's complaining of chest pain. He's got a history of hypertension. You get there, he says he's been doing yard work all morning and he's sitting at the kitchen table kind of holding his chest. First thing, you get a set of vitals. Looks like his heart rate's 75. That's good. He's got a little bit of a high blood pressure at 168/95. Statting fine on room air. Blood sugar's normal. And then quickly, because this is a chest pain call, you want to get your EKG within 5 minutes, and this is what you see. So I'll give you a second to take a look at this, come up with your own diagnosis, and then we'll go through it together. All right, so we start the same way every time. We're going to do our rate first. I like to let the computer do the work. We've got a rate of 72 according to the computer, and what we're going to do is find a QRS complex that matches up with a thick red line and march down and count down. So let me see if I can find one. Let's do this one right here. So this one lines up with a thick red line. We'll do 300, 150, 100, 75, 60. It's between 60 and 75. I agree with 72. Looks like our rate is there. That's normal. Moving on to our rhythm. We ask two questions here. Is there a P wave before every QRS? And does this look regular? So first we're going to look for P waves. Here's one. Lead 2 is going to be your best place to see this. I see one here. As we march out across the leads here, it gets a little fuzzy with a little artifact, but pretty much generally with every QRS, I can find what seems to be a P wave. It's hard right there because of the artifact, but I'll go ahead and call this sinus rhythm. Then the question is it regular or not? Do I see any tiny spaces between QRS complexes or big long ones that would suggest irregularity where I need to look a little closer? These seem to march out pretty regularly. I would say this one beat here where we didn't see a P wave looks a little bit longer, but in general looks pretty regular. So we'll go ahead and call this a sinus rhythm that's regular. Moving on to our axis, this is where we look at leads 1 and leads AVF for help. If you remember, lead 1 is our left thumb. We're looking at the majority of the QRS vector here. I will give them credit for this. This one is, you could almost call it isoelectric, but I think it's a little bit normal here. So up in lead 1, but you could maybe make an argument. I don't have calipers to pull out. And then AVF. I know I'm glancing over some glaring irregularities, but we'll get to those in a minute. So AVF is our right thumb. The majority of the QRS vector here is up. So we're with 2 thumbs up in 1, up in AVF. Our axis is normal. Moving on to our intervals, this is where we look at our QRS. It's less than 120. That's good. QTC is the next thing that we worry about. That's 393. It's less than 450. Happy with that. We'll call our intervals normal here. And then lastly, we look at all this other stuff before we move to our ST segments, which I know you're anxious to talk about. I read it the same way every time. So I like to start with the inferior leads, 2, 3, and AVF. And what we see here is ST elevation. And so the baseline, your S wave and your T wave should be in a straight line there. There's ST elevation above the baseline there. Same thing in lead 3. Same thing in AVF. This is not subtle. These are developing those tombstones that you hear talked about. So we have more than 1 millimeter of elevation and 3 contiguous leads. So this is incredibly concerning for STEMI. Moving on to look for reciprocal changes. A lot of times when you have inferior problems, where you're going to see changes is in your lateral leads. And we do see reciprocal changes here with ST depressions and T wave inversions in lead 1 and lead AVL. And then you don't want to, just because we already kind of have our diagnosis with an inferior STEMI and the reciprocal changes, don't forget your other leads in the anterior and the high lateral side. So moving forward to the front part of the heart, we have our septal leads here. Oh my goodness, there's still some ST depression here. V3 maybe subtle, but still some ST depressions there. V4, 5, and 6 look okay. So what we're seeing here meets STEMI criteria. We have elevations in 2-3 AVF with depressions in 1 in AVL, and then we also see depressions in lead 2, V2 and V3. Now what are we looking at here? So these ST depressions, if you're thinking about leads 2, 3, and AVF, these are your inferior leads, they're called inferior because they're looking at the inferior part of the heart here. You see that? And where you're going to see the changes, the reciprocal changes to that, is the part of the heart that's looking opposite. And so AVL is huge here. This is a really good friend when you have any changes in your inferior leads. AVL is going to be kind of the red flag that something's going on. So if you ever have an inverted T wave in AVL, that's never normal, and that should really signal you to look hard at 2, 3, and AVF. It's the only lead that has kind of the superior view of the heart and is able to see those inferior changes really well. So keep an eye on AVL. That's a big clue to inferior problems. All right. And then we're also, in this particular 12 lead, we're seeing some changes, some also reciprocal changes in lead V2 and V3, and we'll talk about why those are important in a second. But as we think about anatomy and what's going on here, the right coronary artery coming off right here, in the majority of patients, about 80% of the time, is what feeds this inferior part of the heart. Sometimes, in about 20% of the population, it's the left circumflex that actually comes around and is a little bit longer. Everybody's anatomy is a little bit different and feeds this bottom part here. And so it's important to kind of be aware that maybe you could recognize this on a 12 lead. I don't expect you to, but it's good hip pocket information for you overachievers out there. But the right coronary artery is going to feed this inferior septum here. Remember, you got your right and your left side of the heart, and then your septum kind of divides the two. And so in these patients, the inferior septum is fed, and then what's going to be your big suggestive factor that's our RCA occlusion is your elevation is going to be greater in lead 3 than it is in lead 2. And then you're going to see ST depression in lead 1, which is exactly what we just saw, as opposed to maybe a person who's got a left circumflex occlusion. Lead 2 and lead 3 are going to have about the same degree of elevation, and you're not going to see elevation. You won't see depression in lead 1, you'll see elevation in lead 1. And then also in 5 and 6. And that's because, if you think about it, the left circumflex here, you're going to have, if that's your inferior leads, but you're also going to have elevation here because that's where the occlusion is, more on that lateral side. So another question that we ask is, could this be an RV infarct? And this used to be a little bit more important when we gave a lot of nitro, because it could really drop somebody's pressure if they were having an RV infarct. We're not so worried because we don't give as much nitro anymore, but it's still good to know, because if it is an RV infarct, it's preload dependent, and you want to give fluid if they start to get sicker or start to crump. And the clues that you should get a right-sided EKG is if you see elevation in V1, or if you see elevation in V1 with depression in V2. And then here is where our 12 lead comes in. We've got a lot of depression in V2, if you remember. And so I would be very suspicious in our 12 lead, since we have elevation in lead 3 greater than lead 2, and we have big ST depressions in V2. I'd be very concerned that we have a RV infarct. And all you really need to do, I'm going to tell you a quick way to do it. You can move all the precordial leads on the right side with the same anatomical landmarks, or the quick way to do it is just take V4. V4 is very specific for RV infarct. So you take your sticker from here, you move it to the same place on the other side of the chest, you print your 12 lead, and just realize that when you're looking at V4, realize it's your right-sided V4. And if you have elevation there, that's very specific for an RV infarct. So it's a quick way to do it. Just remember, with these inferior STEMIs, this is the arteries that feed the SA node and the AV node. If these patients are going to get worse, they typically get bradycardic or develop blocks, so you need to have the pacer on them. Remember, STEMIs are inherently unstable, and you want to anticipate any changes, and these are the changes I would anticipate. So have your atropine ready, be ready to pace, think through those processes before you actually have to do them. And here's one more look, just because we talked about this so much. This is a sinus rhythm with an inferior STEMI elevation in 2-3 AVF. We've got reciprocal changes in 1 in AVL, also deep ST depressions in V2, concerning for an RV infarct. And that is it for today. Thank you for your attention, and I'll see you next week.